All right, thank you for joining us. Day 3 of the conference. I appreciate it. As people start to filter in, we'll get started with our session on pediatric updates. I'd like to introduce the session moderator, Dr. Karen Flotildes Romo, to lead this session. Looking forward to it. Dr. Romo.
All right, good morning. Good to see everybody. Hopefully you guys got a chance to get out there and go for the run for the Timothy Ernst Foundation. We absolutely appreciate your support for that. I am super excited to join next year. This year I have an excuse, doctor's orders. Can't do it. But I am excited about this session. I'm excited to have both Drs. Mitchell and Dr. Tan here. But before I get started, I also want to recognize Dr. Samaya and Dr. Hansen for their fabulous job in putting this educational content together for us here today. It's good to see all the familiar faces, and then welcome to all the new ones. And we hope to see you again next year and also at the mid-year in between. So Dr. Matt Mitchell is a pediatric anesthesiologist from Hudson, Ohio. He did his residency training at South Point Hospital and went on to do a fellowship in pediatric anesthesia at Cincinnati Children's. Dr. Mitchell is currently the Associate Director of the Outpatient Center at Akron Children's Hospital, where he recently joined the cardiac team. He has a passion for acute pain and regional anesthesia. In December of 2021, Dr. Mitchell started the neonatal and infant spinal program at Akron Children's Hospital, which he will be talking about with us today. Dr. Jonathan Tan is an assistant professor of anesthesiology and spatial sciences at Children's Hospital in Los Angeles, the Keck School of Medicine, and the Spatial Sciences Institute at the University of Southern California. It's a lot to say this morning. He is board certified in anesthesiology, pediatric anesthesiology, clinical informatics, and medical quality. He held several honors, including the Joseph E. Robert Jr. Fellow in Pediatric Surgical Innovation, the Senior Fellow at the Leonard Davis Institute for Health Economics at the University of Pennsylvania, Senior Fellow at the Penn Center for Public Health, and Senior Scholar at the Penn Center for Perioperative Outcomes and Research Transformation. I do not have enough time in my life to get all of those, but Dr. Tan, you're amazing. So Dr. Tan is also a member of the Association of University Anesthesiologists. So please help me in welcoming both Dr. Mitchell and Dr. Tan.
All right, well, good morning, everyone. I don't have an excuse for not running this morning. I'm not a runner, but I wish I would have seen you guys out there. Just wanted to kind of talk about something that's kind of become a new passion of mine, the infant spinal program that we started at Akron Children's Hospital, and just kind of explain why I think that spinal anesthesia is a safer anesthetic for kids for specific procedures that we are performing, and why I think that it's when I go into a patient's room to speak to families and to speak to parents, my goal is to present this as the way of doing the anesthetic and have general as a backup, which is contrary to everything that we've kind of do, right? So previous to this notion, I was still going into these preoperative rooms to speak with families, and I would explain that we normally do general anesthesia, but I would like to kind of sway you or talk you into maybe doing a spinal anesthetic. My whole thought process has shifted now to where this is what I go into the patient's preoperative room to discuss this with general as a backup. So we'll kind of explain. So we'll start here talking about the current standard practice for general anesthesia. What were we doing? Essentially, if we have a neonate come to us or we have an infant, we're doing a general anesthetic, and we'll usually put a cottle in. We'll use an artificial airway, the anesthetic agent, whether it be sevoflurane, narcotics are used. Emergency room anesthesia can be problematic for these kids. So what is the typical standard? So kids come to the operating room. We would do a mask induction after all of our monitors are on. So get them off to sleep with the sevoflurane, put an IV in somewhere. If we're doing a coddle, typically for urologic procedures or things like that, we would try to put the IV in the foot or the saphenous vein, just so that we're something that they don't feel after procedure, taking it out. Not that that's that big of a deal. After the IV's in place, we give medicine, obviously, to them, to perhaps a paralytic, some narcotic, an induction agent, and get the tube in to help breathe for them, at which point we would flip them on their side, do a coddle, and the surgeon would do the procedure, at which point afterwards we would take that intubation tube out, head to the PACU, and recover. So what becomes problematic with, let's say, neonates? So how did this come about at Akron for me? We'll talk about 2 neonates that came to me. It was about 3 o'clock. Things usually roll kind of slow down at 3 o'clock. I don't believe I was on call, but I had 2 neonates come to the preoperative area. They were former premature infants. I think they were 30 weekers at the time that I got them. I think they're 2 months old, so we're about 38 weeks at where they were. Essentially, first one, wasn't even thinking spinal anesthesia by any means at this point, but first one got back to the operating room, induced the child. We have students who are teaching hospital, so CRNA student tried to intubate, couldn't get the intubation. CRNA tried to intubate, couldn't get the intubation. So I went up and intubated the child. Everything was fine, did a coddle, all this stuff, all the things I just explained. And then towards the end of the procedure, with a 38-week child, if you're used to taking care of them, maybe you're not, towards the end of the procedure, the emergence could be delayed. It could take a while to try to get, depending on how much narcotic is given. Obviously, you would want to stick to 1 to 2 mics per fentanyl per kilogram, but that could be delayed. And in this situation, I had a urologist who was super cool, no issues whatsoever. It took a while to get induced. It took a while to get the intubation, and then it took a while to emerge. It took a while to get to the PACU. So all these things, not saying the time is the most important things with these. We'll talk about that, but safety. But it dawned on me after this situation, I was like, I have a perfect situation where I have 2 twins. They are identical. They're both neonates. I just did a general anesthesia on one. I'm going to talk to the urologist and say, hey, do you mind if I try to do a spinal on this next one just to see the difference and see how things were to transpire? He's like, absolutely. I was super excited about that idea. I think that'd be great. So did a spinal on the second one, got back to the room. Spinal went in without a hitch, breeze. Kiddo stayed, well, they usually fall asleep, but stayed awake in the sense of no general anesthetic, right? Didn't have to worry about the induction, didn't have to worry about getting an intubated kid, didn't have to worry about emergence, heading to the PACU all that time. Essentially, at the end of the case, all said and done, the case was probably a quarter of the time that the general anesthetic was. Again, not just about time, but we'll go on. So how does general anesthesia affect these kids? So although he's extremely cute, this guy, what can the effects happen? What's going on with the heart? What's going on with the lungs? What's going on with the brain? So although an ex-preemie, there's a lot of complications that can occur with these kiddos. So it's safe, obviously. General anesthetic is safe, but what are the possible short-term complications? So hypoxia, bradycardia, hypotension, brain cell death, neurotoxicity, death, obviously very rare. So these are some of the things that can occur with the general anesthetic. What are the long-term complications? They can become problematic for the ex-premature infants, multiple GA exposures, neurotoxicity. So there's no definitive answers yet. So we have some studies, the gas study, things like that, that show a significant concern has been raised with regards to potential neurocognitive effects of GA. So in the pediatric world, we are trying to limit the amount of general anesthetics that we do on children that are less than 2, and we try to keep it less than 2 hours and try to do less than 2 anesthetics. some of the neurocognitive things and the research studies that are out, nothing's come out yet that says really there's really any neurocognitive decrease and things like that, but it's still something that we try to prevent. So this is a way that we can do that. So the FDA came out with this new warning stating exposure to anesthesia sedation medicines for lengthy periods of time may negatively affect the brain development in children less than 3 years. That's where we get our 2 years, 2 hours, 2 anesthetics, right? I came from Nationwide Children's. I started at Cincinnati Children's, and I went to Nationwide Children's, and I'm at Akron Children's. So we started the program in Columbus, and so a lot of my slides are from there just because this start in Akron Children's is very new to everyone. So, but this is a kind of an article that they did in the Columbus Dispatch to try to get this to go mainstream. The Wall Street Journal also had an article, and it's basically trying to get the information out there that we can do spinal anesthetics on these kids and have them not have to undergo general anesthetic. So this is one of the physicians, Dr. Schloss, is doing a spinal here for a urological procedure. So why are we doing spinals? Like what's the whole reason behind this? Is it the neurotoxicity? I mean, that's one thing, yeah. I mean, the FDA came out with that. So people always, parents are concerned about what is general anesthesia going to do to my child? What is general anesthesia going to do to this little baby that is maybe only 28 weeks premature? What can you tell me about what the general anesthetic effects can? And we say we can't really tell you too much about it, but the studies are still yet to be said. However, it's everything else, right? So respiratory stability in this situation, you don't have to intubate this kid, decrease apnea risk, cardiovascular stability, less narcotic use, greener approach. This is a lot of things going on nowadays. We're all tasked with trying to be very aware of the amount of narcotics that we use in our patients, whether they be adults or kids. We're trying to limit the amount of narcotics that we're given. Well, this is a perfect example of a way that we can do an anesthetic that limits the narcotic use. The greener approach, I throw this in here because there's a lot of studies with trying to decrease our carbon footprint. And with sevoflurane or nitrous oxide, all the medicines that we use, trying to limit the amount of gas that could possibly has greenhouse effects. So that's just a little newer nuance that we can kind of help. So compared to general anesthetic, infant spinal anesthesia has documented decrease in all of these things. So apnea, hypoxemia, bradycardia, laryngospasm, post-op. Obviously, anytime that you're going to put a tube in a child, you can have issues getting the intubation. You can have issues while the tube is in place, previous to or after. So after we take the tube out, it can go through a laryngospasm. After taking the tube out, you can notice that your child has croup because possibly there's some issues or edematous situation on the vocal cords. But you can add bronchospasm to this as well, right? Any of these things could possibly happen. So the nice thing about these spinal anesthetics or these kids, we're pretty much not requiring any oxygen during these procedures. So here's the gas study. Infants randomized to the regional technique had substantially greater mean systolic blood pressures and were less likely to need intervention for hypotension during anesthetic. It can be done in any pediatric center. So we can get into what it took to kind of start at Akron, or one of the things that I would love to just I can answer any questions, or if there's emails or anything like that, of how to get this started at your facility or wherever you're working, whether it be outpatient, whether it be inpatient. But it can be done and can be replicated. So an awake regional technique is more efficient, requires less time. We kind of talked about that. Currently, all of our docs are urologists, and I'm kind of moved this into the pediatric surgeons as well at Akron Children's. They are still we do change our time on a rolling 10 case average, but with the general versus neuraxial, we kind of kept their times the same. It's been nice to kind of see when you have a lineup of 6 or 7 cases that are all spinals, as opposed to generals, how much time you're actually saving. Any given time, if the circumcision, for instance, is scheduled for 60 minutes, you can pretty much guarantee that you'll be off the table within 30 minutes. So we're cutting our times in half for the most part, which is pretty crazy. There's no time that is required for the emergence, the extubation, that we've talked about all those things. So Vermont is kind of the University of Vermont is kind of the go-to for this. This is something they started in the 80s. I think a lot of times in anesthesia, things come in and come out a lot, right? So when I talk to a lot of the older surgeons, they would say, when they're in fellowship, yeah, spinal was what we did on these kids. We did spinal on all these. And then somewhere along the way, we stopped doing spinals and we started doing general anesthesias with coddles. Now we're kind of, at least what I'm talking about is trying to get that spinal to come back into play. But here's just at Vermont, the efficacy, the shorter than the regional group, 51 minutes versus the GA group, 66 minutes. So 15 minutes that we're saving right there. So what else is helpful is time to first feeds is shorter, less opioid analgesia within an hour. So the gas results, the time to the first feed. So this is something that parents are pretty concerned about too, right? Like they've had their child who is typically, whether it be breastfeeding or having formula or Pedialyte or anything, essentially the MPO, they need to be MPO because we're doing general anesthetic, whether that be 6 hours, whether it be 8 hours. It's a child that's not used to going that long. So you have a very irritable child who parents are feeling that irritability and want to get their children fed as quick as possible. Well, in the spinal situation, it's quicker to that feed. I would say, I don't know that I would recommend this, but I have children who I've done a spinal to. I know that it's a circumcision. I know that the spinal is working because it starts acting quite quickly, and sometimes difficult to get the child to. They're kind of inconsolable because they're so hungry. I don't suggest this necessarily, but in these children, if I know the spinal is working, I have a urologist that I'm very used to working with. I know that he's going to be off the table in 10 minutes. I know the only thing that this kid really wants at this time is either sleep or food. I don't suggest this to anyone out there, but I will go to the PACU, I'll get a bottle of apple juice, I'll take it into the room, and then I'm feeding the child while he's having surgery. Kind of crazy, but our MPO guidelines are changing. I'm not saying that we should be giving food to children in the operating room, and I would not encourage it. It's just something that kind of gets our kids calmed down. Most of the time we use sweeties for these, so we'll dab their pacifier in like a sugar solution, and that kind of keeps them calm. But some of these kids just can't calm down. So let's talk about the spinal patients when they go to the recovery room. So what's going on? We're diverting resources in the PACU so that the nurses in the PACU can take care of maybe more complex patients. Essentially, we have the operating room for the kids getting a spinal, PACU to recovery room, there's no parents, and the surgical discharge units where the parents can come back, and then home. So what are we doing? We're bypassing this phase one. I don't know what's happening in your guys' institution, whether phase one and phase two of PACU is in the same spot. There's two different situations at Akron Children's, one being the outpatient surgery center, one being the inpatient side. The inpatient side, the PACU and the phase two, so phase one and phase two are in two different locations where they're kind of wheeled across the hallway. So it's actually two separate entities. In the outpatient surgery center, phase one and phase two is the same nurse, same place, so it doesn't really matter as much. However, the nice thing about this is our kids that are undergoing general spinal anesthetic are essentially bypassing phase one. They're straight to phase two. As soon as that child is moving his feet, moving his legs, they're discharged. They're able to go home. Super satisfying for the parents to know that they don't need to wait in the PACU for 1 to 2 hours to wake up to make sure things are going okay. It's a nice satisfier for them once the kid is moving. So what do we do in that situation? Well, we time what anesthetics we're using in the spinal so that it goes well with the procedure that they're having. So a lot of times we can time it so that the kid, right when they're pretty much finishing up in the operating room, starting to move their feet and their legs, so essentially they're going home as soon as they hit phase two. They'll get one set of vitals, and as far as that's concerned, kiddos can head out. So it's pretty nice. So basically, yeah, we're going operating room straight to the surgical discharge. The parents come back and straight home from there. So we optimize resources, can get nurses to take care of more complex kids. We reduce the harm and we decrease the cost. Early reunion with the parents, eating, huge satisfier. Not only is that a satisfier, but I don't know for sure, but I think a PACU phase 1 charge is similar to, in 15-minute increments, is to an ICU stay. So if we can limit that and the amount of cost to the hospital and the cost savings to the family, it actually becomes quite large. So bypassing the PACU is saving $1,300. This was at nationwide. We're running numbers now at Akron to try to figure out, there's a quality program going on now to see how much cost savings is going on with the hospital though. But if you do 250 of these cases a year, we're saving $300,000. So better, safer, but also time efficient, also reducing cost. So better value. So preparation, patient selection. So this was at Nationwide Children's, but what do you need to do these children? Well, you have to have the right patient, you have to have the right procedure, you have to have the right surgeon, you have to have the right, obviously, needles and things like that, and then the staff around, so to kind of allow you to perform this. So the right patient, who's the right patient? Well, it depends, right? When you're starting at a different facility and you're starting something, you want it to be successful at first. So what did we roll this out with? We rolled it out with kids that were usually probably less than 12 months, so less than a year old. So anywhere from 6 months to 12 months, any kids that are about 10 kilos, maybe less. It's easier to hold them. It's easier to place the spinal, and it has a higher success rate. You need the right surgeon too. You need someone who's efficient. I don't want to say fast, but efficient. You can't have a surgeon who takes a long time for these procedures. Our urological group at Akron Children's has a unique situation with the hospital in the fact that they are private, but they're not employed with Akron Children's. They're semi-employed. They have a contract with the hospital. So they're efficient. They're a private group still. They still want to get things moving. They still want to move. So it's a perfect group that we rolled this out with. And then the perfect, so we talked about the patient, the surgeon, now the surgery, right? So you want to roll this out with simple things, circumcisions, inguinal hernias, things that are quick, things that don't usually take longer than an hour, and that will increase your success rate. After you do those things, you want to start pushing the envelope. I've started pushing the envelope quite a bit at Akron Children's. So the urology group that we got this started with, I moved it over now to the general surgeons. So, but you can add things to your bupivacaine. We use 0.5%, which we'll go over, to increase the duration of the block. But not only pushing the surgeries that you're doing. So it started with circs and inguinal hernias, but we started to do bilateral ureteral reimplantations that are 4 or 5 hour surgeries. I've done some laparoscopic procedures with general anesthesia. So some of the general surgeons don't like to do, the newer general surgeons do their inguinal hernias under the laparoscopy. They learned open techniques, but they tend to want to do more laparoscopic procedures. So I've come up with some ways that we're doing these spinals under laparoscopic procedures as well. So pushing the envelope with the patients as well. So no longer 10 kilograms is our lowest. We'll go up to 18 kilograms sometimes. It's a big kid. Wouldn't suggest it. Sometimes it's more difficult. You might need some Versed to kind of help with those kiddos. But for the most part, pushing the envelope with the age as well. So last week we did a 26-month-old kid. So you worry about them kind of remembering things at that point. So I will give those kids Versed. But now that we got this off and running, we no longer keep it to a 10-kilogram kid, just 12 months, pushing the envelope a little bit, because I do believe that it is a safer anesthetic. So here's some of the things the medications that we're using. I'm specifically just using 0.5% bupivacaine. There are other ones that have been used in the past, whether it be tetracaine, ropivacaine, but we're using 0.5% bupivacaine. So what's the recommended dose of the bupivacaine? 0.5%. It's isobaric, up to 0.2 mLs per kilogram with a max of 5 milligrams. I push this a little bit as well. So essentially, most of your kids are going to have 1 ml of 0.5% bupivacaine that you're injecting into the cerebrospinal fluid in the back. If they're a little bit bigger, like some of those bigger kids, I'll use 1.2. Now, what does that get you? What kind of duration of a block does that get you? 0.5% bupivacaine in 0.2 mLs per kilogram gets you about, it's spot on, about 50 to 55 minutes. So if I add clonidine, 1 mic per, I'm getting that up to about 115 minutes. So things like hypospadias repairs and things like that, I'm adding clonidine. So what needle am I using? I use a Quinky, and might sound crazy, but again, when you're starting, if you're starting this, you might want to use something that's a little bit bigger. So most of the time when I'm trying to train the physicians or the other anesthesiologists at Akron, we're using 22 gauge Quinkies. With the neonates and things like that, I'll use a 25 gauge needle. I tend to use a 22 quite often. You get the CSF comes back pretty quick, you know you're there. You can inject that local anesthesia in and be on your way. It's pretty a nice needle to use. So essentially, just want to kind of go over why or how these are quick acting on and off. So the CSF volume in neonates we know is about 10 mLs per kilogram. In infants and toddlers it's 4, in adults it's 2. We all know or have learned in the past maybe that about 500 mLs of CSF is replaced on a daily basis, whether you're a kid, baby, adult. So if you have a neonate that has a CSF volume that's higher, you know that that's being replaced quicker than it is even in the adult world. So the pia mater is highly vascularized, the cardiac output is high. So what does this result in? It results in a rapid absorption of the local anesthetic, so you get a shorter block. So the block's not going to take, or not going to, it's going to set up quick, it's going to come off quick. It's a faster onset, it's a faster offset. So the things that we worry about in the adult world versus the pediatric world, for adults, obviously we get a sympathectomy, right? For adults, we get some hypotension. For adults, there's things cardiovascularly that we want to limit the reason or why we would do a spinal anesthetic. You're not seeing those things in kids because of some of these. So this is just kind of discussing or showing the holding of the kid. So I will tell you, when you're trying to start this, if you were to start it, or the most important person in the room for a spinal anesthetic is not the person doing the spinal, it's the person holding the baby, right? So you need a baby who is being held still, and essentially this is the most important person in the room, because if you have a moving baby, you have a moving target, it becomes a little bit difficult to put that spinal in. So I've had to train, we have CRNAs at Akron Children's. We have 8 or 9 CRNAs right now that are on the spinal team that I've trained to kind of help hold the baby and how to hold them. They've all got their own ways of doing it, but essentially this is the most important person, and I let them know that they're the most important person in the room, because they're the ones who help us get the spinal in. So you can do them lateral, but we do everything at Akron. We have them sitting. So performing the block insertion, L4, L5, L5, S1, loss of resistance, not feeling that ligamen flavum. It's just tiny. But after you do enough of them, 6 in a row, last week we did probably 15 or 20 spinals just alone in the week, depending on who's in that room. If you're doing your 6th spinal for the day, after doing multiple of these, you're kind of getting used to what that feel is, and when you need to take that stylet out with the Quinky, and you're pretty much know when you're at the right spot, but you do not feel that ligament like you would in the adult world. The reflux of CSF in a 22 gauge, you can imagine, maybe sometimes the baby's crying. That CSF will spray back on my scrub sometimes because they're that ticked off and they're crying. So 22 gets the CSF flowing quite well, and you can attach that. Usually the syringe that you might use might get the easier lure locked ones that can kind of go in there. But 25 gauge, again, it doesn't come back as fast, and we use that on our the small guys. So here's just a kiddo who had a spinal placed. Hope that ID badge is clean, because that's gross otherwise. He starts putting that in his mouth. There's something about these kids that once the spinal is placed, there's something about them losing that sensation that they typically fall asleep. There's something about the deafferentation that causes them to sleep. Now, some of them are hungry, some of them don't fall asleep, but I would say a majority, 85-90% of these kids, once that spinal gets placed, they're already tired, probably it's nap time, they're hungry, there's something about it, and they go ahead and fall asleep. For the older kids, I purchased Amazon or something, just a cell phone holder. So we always put a ether screen up or something so the drapes kind of lower, but I'll put a cell phone holder on the ether screen. And I typically ask moms, dads, what's your child's favorite show? Right? Maybe Paw Patrol or something like that. So a lot of times we're putting a cell phone with Paw Patrol on, and the kid's just literally watching Paw Patrol as he's getting surgery. Works out very nice as a satisfier again for the parents, because their kids are watching their favorite show while they're getting surgery. Everyone's at ease because they're not getting a tube down their throat. There's no general anesthetic, and it's a pretty safe technique. So we kind of talked about this. Children have smaller peripheral circulating volume, immature sympathetic nervous system. So essentially absent sympathectomy, absent cardiovascular effects, safer anesthetic. So basically, when we get that spinal in, one thing that I would say that we like to do, if there's an arrow pointing to the towel here, we try to get a towel underneath their shoulders. We don't want them lifting up the children to put a Bovie pad on or anything like that on their back or their bottom right away once that spinal is in, because then you might get that high spinal, right? Most of the time, our spinal is acting at the umbilicus and down. But I've yet to have a high spinal, which knock on wood, hopefully I don't. But doing things like this, having a towel that's folded in behind the shoulders, is kind of helpful to kind of prevent that, and then just make sure that it's setting up before they lift the baby to put the Bovie pad on and things like that. After the spinal is placed, we get all of our monitors on, so we don't put on any monitors. We talked about the cardiovascular risk, we talked about the sympathectomy, things like that. If those are pretty much absent, we don't need monitors for these kids. We do during the procedure, obviously, but we go into the room, the person, the CRNA is holding, spinal's in. For what we're at right now, I have kind of coached the CRNAs. They go and they meet the family, they pick up the child, I make sure the child has the shirt off. We put EMLA cream on their backs, usually about an hour before the procedure, because we're trying to prevent them feeling as much of that needle poke as possible. The CRNA goes with a warm blanket, picks up the child, heads to the operating room. From the time that they're in the operating room to the time that the spinal is placed, I would say it's typically about a minute, maybe less. So nurses in the room get a little worried when the kid's crying at first, but I always tell people the proof is in the pudding. So everyone's concerned that the child's crying because they're in pain and things like that, but really the reason why the child's crying is because they've never been held facing someone. They're always held facing out. The reason the child is crying is because they're not with their parents at this time. They're with some people that they don't really know that well. But at these ages, maybe that doesn't matter. But we try to prevent any pain with that EMLA cream, and we're not giving much sedation for the younger kids. The Versed obviously helps with this, but just kind of go over a few of those things. So sedation, do we use it? So like I said, there's this deafferentation and reduced stimulation of the reticulating activating system, so you get some sedation. What else can cause sedation? There's some of the additives, the medicines that we give, right? So if I'm putting clonidine in the bupivacaine solution, that is aiding in a little bit of sedation, usually 1 mic per. If you go up to 2 mics per, you might get a little bit too much. So conversion to GA due to failed or inadequate block is rare. We're about 98%. So the reason why we've had to convert to GA or do GA is mainly because we have a younger child, can't really console them, they're kind of angry, and you're getting a heme tap, you're getting blood basically back. And when you get a blood tap, you gotta try to go quicker, usually higher, and then you hope that you get CSF. But the main reason as of now that some of these are failing is because we're getting a bloody tap, and that's pretty rare though. So we have some major studies for spinal anesthesia. So less than 1% required airway support, less than 1% had any drop in oxygen levels, 95% only needed room air for surgery, and less than 2% had low heart rate or blood pressure. And this is from over 300 spinal anesthetics and 0 complications for all of these. So I kind of talked a little bit about pushing the envelope a little bit. So Whether we're doing bilateral or ureteral implants, how do you say we're getting 4 hours of block time for a spinal or we're not? We put a spinal in, we use clonidine, we're getting 115 minutes with that. After the spinal goes in, we're flipping these kids on their side and we're doing a caudal epidural for them. And we're using chlorprocaine that we usually start about a bolus. We bolus about an hour into the procedure, and then we'll start the chlorprocaine, and that basically kind of bridges the gap from when the spinal's wearing off. Usually, like I said, about 115 minutes. Chlorprocaine is started an hour in, so about 60 minutes we're starting that, and that bridges the gap, and these kids do great. They're awake. They are awake for a 4 or 5 hour procedure, which would typically have an anesthetic, general anesthetic. It's a great, great thing. So there's other surgeries. I haven't done any for the Achilles lengthening, but the orthopods are the next group of surgeons I'll be going after, not going after, but try to get to use spinal anesthetic for our kids. So here's our advantages, kind of what we were talking about. General anesthesia is not necessary, right? Reduced incidence of apnea, bradycardia, desaturation. It's cheaper. It provides a balanced anesthetic with minimal complications, minimal postoperative nausea, vomiting, short time to ambulation, home quicker, right? Intubation, respiratory effects. Opioids we're not using. Anesthetic drugs can be avoided in the high-risk situations. A lot of these kids, as you know, if you do peds that come in for elective procedures are, can you find me a month time frame where a kid's not sick, whether they're going to preschool or daycare, and if you're canceling these kids time and time again, you're never going to do their procedure. So a lot of these kids might have a brewing cough or something viral that's underneath that you haven't seen yet. Unfortunately, last week I just had a kid who had somewhat of a little bit of a cough, was there for a circumcision. Parents didn't want a spinal. I tried to tell him we should do a spinal, and unfortunately in that situation, the kid did fine, but I couldn't get his saturations up in the post-operative period, and so he had to stay the night from the outpatient surgery center. We had to move him over to the hospital. Does that happen every time? No. And it's not a I told you so moment. It's just things that you can prevent is respiratory issues with these kids by doing a spinal. If they're somewhat sick, because you don't know, sometimes their sats are good and they might have a little bit of a runny nose, but sometimes they're not presenting like they have a virus or are sick. And when you do a general anesthesia and you put a tube in, all of a sudden you find out when you're extubating that, man, this kid was sick. I didn't know. There's no fever. There's nothing showing it. But now I have an issue in trying to get their sats up in the PACU. So obviously with malignant hypothermia would be the preferred technique. So limitations, single shot additive free technique provides 70 to 80 minutes. We talked about the time is the limiting factor in these situations. The other thing that I personally was worried about, right? If we're doing a general anesthetic with a caudal for these kids, we have a post-operative pain relief for 6 to 8 hours is usually with that caudal. So when we're doing a spinal, and that's the sole technique, are we getting any of that post-operative pain relief? We don't know necessarily. If you do a spinal, you're kind of knocking off that afferents there, so it provides a post-operative pain relief. But what I've started to do is have the general surgeon, urologist go ahead and give a penile block or whatever block that they would normally do for a procedure at the end of the procedure to gain the post-operative pain relief that you would normally get with a caudal, or if you had a patient or parent who didn't want a caudal, then they would normally do a block anyway at 0.2% ropivacaine. I'm still trying to figure out the parents that do not want a spinal but want a caudal. They want general anesthesia with a caudal. I try to explain to them, I don't understand that. The biggest thing right now that I have is the issues with parents is because mom had a spinal at one point, or someone had a spinal that they heard about and it was terrible for them, and I try to explain to them, this is different. So with this, our research provides, this can read this quote, but we found that spinal anesthesia is safer than general anesthesia. When I go into that room, I tell the parents, if this were my child, I have 4 kids, I would do this for all of them. If they're a neonate or an infant, I would do spinal anesthesia over general anesthesia every single time. I try to explain that to them. I don't push this on them. I just tell them this is what I would do. This is the safest technique. It's a beautiful thing. And so, but that is spinal anesthesia. So thanks, guys. Appreciate it.
the conversation of the parents and the URI is my favorite. The wheels were turning in my head. I think we're going to have you come over to CHLA and talk about this and promote it at our place as well. I'm going to turn the floor over to Dr. Tan. He's a dear friend and colleague of mine, and he's going to talk to you about informatics.
I'm really excited to share with you about some of the work we're doing at CHLA and University of Southern California, how we're going to improve the future of the way we think about our kids, whether it's in the operating room, it's in our pain clinics, whether it's how you run your hospital even, and just a different way of looking. And I'm excited to share this with you for the next 30 minutes. So I wanted to thank the Anesthesia Patient Safety Foundation and FAIR for their incredible support, not just with grant funding, but also with the platform that they provide to help us with our research. Love to thank the University of Southern California as well for some funding they're providing for this work as well. And I want to highlight an academic strategic partnership that we have with two companies. We have no financial conflicts of interest with them. One's called Plume Labs. They're a data science company that was based out of Europe. They recently got acquired by AccuWeather. The goal of Plume Labs was to provide and network all the air quality sensors in the world in order to provide the most granular information about the air quality that we experience. They were recently acquired by AccuWeather, which I think requires no introduction. Most of us use AccuWeather for our daily weather updates. They serve 1.5 billion readers around the world every year. Just some objectives. We're going to describe social and environmental determinants of health. I think we hear a lot about social determinants of health and the environment. And the question always is, well, how do we measure that? And how do we bring that into the fold of the hospital? How do we use that information, the disparities that might exist related to that, to help us think about our kids and better serve them and their families? And then I want to provide two real-world examples that we're using this information, this new insight in our hospital today. Okay. I want to start by just introducing the concept of something called intersectional innovation. This is a term coined that's often used to describe the Renaissance, the idea that you bring artists, engineers, scientists, poets, all into one place, and with different backgrounds, different education, different experiences, they're able to bring that all together in order to come up with new ideas, new thoughts, and changes the world at times. I think in very much the same way, I would love for all of you to think about that in the context of today's talk and how we can think about public health, anesthesia, pain medicine, informatics, the environment, air quality, and geography, and to how we use all that to bring together and to how we think about our kids and our future. With that said, I want to take you to Los Angeles. I think many of us have heard about Los Angeles and have been there. Beautiful beaches, beautiful mountains as well. It's a fantastic place to live. I moved there 2 years ago, and it's been really wonderful. This is our work home, the Children's Hospital Los Angeles. We're the largest West Coast children's hospital in the country, and we serve about 24 to 26,000 anesthetics a year, and it's about 400 plus beds, depending on our nursing staff at given times. But when I think about Los Angeles and I think about Children's Hospital Los Angeles, and I think about the patients we serve, there's a lot more that goes into it. All right, there's driving. There's a lot of driving in Los Angeles. And with that, there's a lot of traffic. And with that traffic, one wonders whether the traffic and time of day of travel may influence whether our kids show up on time for their surgery, whether they show up on time for their telehealth appointments or their clinic appointments in pediatrics. We also think about a lot of CO2 emissions and the pollution that might be generated from car traffic. The other thing that we think about as well is that we serve an incredibly diverse population, like many of you in your hospitals, whether you care for adults and kids. The diversity is large across race, ethnicity, socioeconomic status. We think about asthma, reactive airway disease, any number of kids that are affected by that on a daily basis. We think about traffic accidents and kids going to school and kids playing outside. One of the number one causes of injuries in kids is trauma. I think about if kids live in old homes that haven't been renovated or live in certain neighborhoods, they're exposed to lead poisoning that may impact the rest of their life. And of course, not just the kids, but we think about the parents and caregivers of these families, of these kids and our patients. And we think about how we can better serve them if they have certain needs socially or economically, or they live in certain parts of our city. How does that affect the care that we deliver? Think about trees also. So if many of you have been to Southern California, there aren't many trees there. And depending on where you live in Southern California, there can just be one tree for many miles. There was a great expose in National Geographic last year and last summer that talked about Los Angeles and talked about the incredible diversity of heat, temperature, and tree coverage there is across the city. This is a great example. There are some parts of Los Angeles where there are 20 trees to every one person. And then there are other parts of Los Angeles that have 20 people to one tree. And in this, some of my colleagues at the University of Southern California are studying the fact that there are urban heat islands that exist. Right? There can be differences of several degrees of temperature just a few miles apart based on tree coverage and design of the urban environment. And of course, there's wildfires that generate a lot of smoke that impact all of our health. Climate, environment, social issues aren't specific to Los Angeles. They affect everywhere. Very recently, we had a mega heat wave that lasted for almost 2 weeks in Southern California and up and down the East Coast and West Coast as well. And temperatures were really hot. And of course, when there are floods, it disproportionately affects certain parts of our neighborhoods. So this is everywhere. All told together, these factors, these different areas of health, what we call social determinants of health. And I think this is a phrase that we've heard a lot about in the last few years, but frankly have existed for over 20, 30 years in the public health domain. And the 5 areas of social determinants of health include economic stability, education, the neighborhood and built environment, access to health and healthcare, and social and community context. And all the things that we just talked about affect every one of us as healthcare professionals, as physicians, but they also impact our patients. So 80% of the health in individual experiences is a direct result of social, economic, environmental influences. This is a very much agreed upon statement by the WHO, the United Nations, the CDC, and many other major organizations. Except we never actually think about this very much in our daily practice. When we have a clinic for pain medicine, when we have a pediatric clinic, when we have our operating room and our kids or our patients are coming through, we don't often think about the other 80% that might be related to the care that we provide. I often call this the demographic data problem. So if you look at a very simple demographic factor study, it's always table 1, right? The classic things that come up: race, ethnicity, measure of age, and maybe the payer status, whether they're public or commercial. And I think there's a reason for this. This demographic data problem really exists because that's all we have from a non-medical, non-clinical standpoint to understand the diversity and disparities that our patients have. And while these are really important factors, and there's no question that there are race and ethnicity differences in the care that we provide that's been well studied and published, there are many more factors as well, many more factors that are as well modifiable. And I call this demographic data problem for several years now, and it's because the EHR has a limited data set available to study social determinants of health. All the things that we talked about: heat, temperature, climate-induced wildfires, poor air quality, tree coverage, all those things don't exist in an electronic health record. And it was the mission to try to figure this out for the last few years, and we're really happy with the work we're making. So how do we do this? Well, we went back to a clean slate, blank whiteboard, and tried to reimagine what that looks like for our patients and our hospitals. And so we started at the very beginning, and we tried to brainstorm different strategies for leveraging information in electronic health records for social determinants of health. Now, we could start at the very basic level with looking at our electronic health record. As I showed you before, there's very little information in a demographic tab related to it. If you're in a children's hospital, the job status or the job status field relates to the child, and really there's not much information there. There's a marital status tab as well if we're interested in that. That's often single for many of our kids. You could survey you could survey every family member or every individual. When you serve 26,000 patients getting anesthesia every year, that gets very expensive, very tedious, although that is a really great way to dive very deep in specific cohorts of patients. But it's very limited, it's not scalable. And you could look at free text notes and something called natural language processing, where you can extract that text out and get some insights, maybe from social work notes. The trouble is, many kids actually don't have social work notes, which is a fantastic thing, right? We don't want our kids often being consulted with social work. So there's some limitations there, although I do think in the future that might be an avenue to pursue. And the last thing, which we'll focus on the rest of our time with, is the patient location. And so when I say the patient location, I mean more than the zip code. I mean the street address. So 123 Main Street, apartment number 2, Glendale, California, and then the zip code to follow. And I say that very specifically because zip code is actually a very large area of geography versus if you look at the specific street address. And if we look at the specific street address, there are a lot more nuances that happen at that scale with your neighbors, your neighborhood, your city block, than actually the zip code itself. And so we use location information every day. I know many of my colleagues go to the Coffee Bean in the lobby of our hospital, right? And so if you're looking up on a Starbucks or a Coffee Bean app on your phone, it's looking at your location relative to location of the coffee shop. If you go to Disneyland or Disney World, you have an app that you can pull up that looks at location and uses location at very fine levels of geography for a specific ride to let you know what your wait times are. And so this is something that's actually very much familiar to us every day, and we probably use this almost every day. And so I would say that the most underutilized variable in our EHR right now, today, is the patient address. So what does that look like to reimagine how we measure and use patient address in our work, in our day-to-day life? So what we're doing is we're taking the individual EHR, our records that we work with every day, and we're adding that with local information from census tract, from private industry companies and data sets to describe the neighborhoods around us. And we're also combining that with environmental exposures. So we're working strategically with Plume Labs and AccuWeather to provide us very fine geography about air quality information, so we can finally get at specific questions about what is the air quality exposure of the kids that we care for in anesthesia. Does that matter? And if it matters, maybe we should do spinals. But if it does matter, maybe there are ways to modify that, right? I'll show you in a little bit later, air quality can impact the number of respiratory adverse events, and that's something that we're pursuing right now. Okay, so here's case study number 1. I arrived at CHLA about 2 years ago, and it was the middle of the pandemic, pre-vaccination, and we're still very much in the throes of telehealth for all of our patients. And our division chief of pediatric pain is a good friend of mine, and we thought we wanted to study a major problem that we were seeing. It wasn't just in the pain clinic, it was actually across the enterprise. But we thought by starting small at this level, at a pain clinic level versus all of the ambulatory surgery centers and all of the pediatric pain clinics, and all of the pediatric clinics actually across Los Angeles, we would start with our own department and our own group. And so what we started looking at were 550 patients over the course of about a year, where they recognized about 14.9% of kids canceled last minute or did not show up for their telehealth appointment. This is a huge operational problem, right? The kids aren't getting the care they need. The healthcare professionals in a diverse, multidisciplinary clinic are sitting around, not able to see a patient. It leads to a financial problem as well, of course. But mainly, the question is, what's going on with these 15% of kids? The staff and physicians and our nurse practitioners also noticed that there was a large disparity amongst this population of those kids who did not show up. And certainly they saw there were race, ethnicity, and language barriers, but there seemed to be a bit more as well. About 52% of patients self-reported race as other unknown. This is something actually, if you look at your electronic health records, especially in a diverse city, actually exists. And in Los Angeles, where there are many mixed race individuals and patients, 51%. So if we're looking at just race, ethnicity as a factor of disparities of care to try to address this, 51% are other unknown. There's not much you can do with that information off the bat. So again, the question was, what are the social, economic, and environmental risk factors that might be related to this, that might be associated with no-shows or late cancellations of telehealth? And can we do anything about that? So we brought in information from the CDC, and this is publicly available data, something called the Social Vulnerability Index. And these are different measures based on census data that we fill out every year. And essentially, it describes the census tract. So that's about 600 to 900, maybe 1,000 people around you, and describes that environment around you. So it may not be your specific economic status or household composition, but it's certainly the immediate area around you. In a major city like Los Angeles, there might be 2 to 4 city blocks. And the first rule of geography is that the people that live around you are more likely to be like you and similar to you in many of these factors than those who live much further away. And so what that looks like is building maps of what the Social Vulnerability Index looks like. And we brought this into our electronic health record and then incorporated that with electronic health records as well. And so here's a video of what that looks like. So this is the map of the world, And as we start scrolling around, we inputted all 550 patients onto this map at a very specific street address. And very shortly, you're going to see some blue dots. Those blue dots are the number of patients, or the patients individually, that showed up for their telehealth appointment on time and completed their appointment without a problem. So at the very beginning, it's actually pretty cool. You can see the diversity geographically of the patients that we serve. There are 2 patients in that year that came from Las Vegas. Actually, there are many more at this point. Bakersfield, California, further down in Los Angeles, Orange County. Of course, the majority come from the immediate greater Los Angeles area. In a second, we're going to see red dots. These red dots are actually the kids who did not show up for their appointment. Right? So now we're starting to look individually at individual patients on a map, and those who showed up to finish their appointment and those who did not show up. And we get pretty specific here. We can zoom in down to their house. We don't publish this information, of course, and there's a reason why it kind of fades out here. But we do this because there are nuances to city blocks, right? And while we don't publish the actual address of our patients, of course, we can use this information to distinguish which kids are having trouble, which families are having trouble versus not. So right now, if you just looked at this map, they look kind of mixed. All the kids looked mixed. The red dots look like they're sitting in the blue dots. But actually, there are nuances to those neighborhoods. If you're using zip code or county level geographies, it'd be hard to tell a difference. But if we're zooming down and understanding what the immediate neighborhoods in a few city blocks are around them, that provides us a lot more information. Okay, so here's just a static map. We call this affectionately the black dot map. And it just describes where all the kids are coming from for telehealth. So you can see that's actually really important if you're a surgeon, if you're a tertiary care hospital that's getting a referral base. Knowing where your kids are coming from might help you describe where should I build that sports medicine pain clinic or sports medicine orthopedic clinic. And these are some of the avenues that we're starting to discuss with our hospital. But then if you break down that black dot map into 2 different colors, again, like the video, there's those who checked out or finished their telehealth appointment, and there are those who no-showed or canceled, right? So this is basically just a picture of the video we showed. You could take that and overlay that over the CDC Social Vulnerability Index map that we created. And so there are 5 different colors here on the Social Vulnerability Index, and from dark red all the way to the lightest in the yellow. And what the Social Vulnerability Index basically shows is that at your census tract, at that small area of geography, if you live in a census tract that's 0.8, you live in a census tract that's worse off than 80% of the census tracts in America. That's a pretty not great place to live, and there are many things socially, economically, educationally that may come with that. If you live in a census tract that's in the yellow area, let's just call it 0.2, you live in a census tract that's better than 98, 97% of the census tracts in the United States. So very opposite. And we see a whole spectrum at our hospital. So again, not just location now, but we're actually able to understand the disparity and huge gaps that we have when we care for our kids. So what does that look like if we take 550 kids and put them on a map and graph it out? So this is just a distribution of the type of kids that we care for in our pain clinic. So the number of patients are on the left-hand side, and on the very bottom, there's the less vulnerable kids and families to the more vulnerable kids and families. If you take a careful look here, our average social vulnerability is 0.69. And we knew that we cared for a very challenging population at most children's hospitals, and especially here in Los Angeles. But what that means is half of our patients that our pain clinic sees live in neighborhoods that are worse off than about 69% or 70% of the nation. Actually, if you look even closer, almost 40% of these kids live in a census tract that's worse off than 80% of the census tracts in America. And so that's interesting in itself. But what it does, it allows us to understand if we add this information, this geographic information, onto our data set, and in addition to the standard individual factors like race, ethnicity, insurance status, things we already know about, we're able to detect much more kids that are at risk and create a better model for understanding who's at more risk for showing up late for the next appointment. And we could do that by doing a hot and cold spot analysis. So this is very much like epidemiology for diseases, except in this case, we're applying it to clinical operations. And so what this shows is a statistical model, right, of the highest risk by location of those not showing up or canceling their telehealth appointment. So if you look at that color there, that dark purple, if a child comes from this census tract near LAX and near Inglewood, this child is much more likely, in fact, 5 times more likely to show up late or not show up for their appointment than a child who comes from Calabasas. And those are very different neighborhoods, and this is based on 1 year's worth of data. And our next step is actually to take this and apply it to the entire hospital for our pediatric clinics as a whole. And the idea is that if we can help identify where are the hotspots in our patients and the patients that we serve that are more likely to show up late, can we do something about that? So what we're doing is actually digital cartography, informatics, and spatial science. We're taking a map, a base map, and then we're adding on top of that some measure of social risk, maybe environmental risk on top of that. And then we're taking electronic health record data where patients live by street address, and we're placing that on top of that map as well. And then from there, we can do some element of statistics to help create a model for those at highest risk for some factor. And in this specific case, it was clinical operations, right? The efficiency of our clinics. And then all that put together allows us to really understand what our patients look like at a deeper, more granular level. And so what we're doing now, we have our pediatric pain clinic, right? And you can substitute any clinic there. You can substitute the operating room there. We're doing some level of risk stratification for those at highest risk by location, by clinical factors. And then the opportunity really is an intervention. So we're doing all this work, not just to show maps, but we're doing all this work really so that we can intervene and reduce that 15% of no-shows and lates in a very efficient way. You know, we can't address all 500 kids at a time or all 5,000 kids at a time. What we want to do is find who are the 20% of kids, 15% of kids at most risk that make up 80% of the operations issues, and then target our interventions toward that. And that's our opportunity. And starting last month, we started putting together a team to use this information, and every 2 weeks going forward, risk stratify our patients and do something differently with them in order to reduce the gap in our no-show and late cancellation rates based on geography, based on neighborhood risk factors, and based on individual risk factors as well. And so we're excited, maybe in a year or so, we'll be able to find that there's a reduction, and this model might be scaled out to the rest of our hospital and our pediatric clinics. Okay. The next case I wanted to show you and how we're using spatial science and location and trying to understand social determinants of health is in air quality. I think there's no secret that when we think about Los Angeles, many of us think of air quality as well. And actually, air quality in Los Angeles has improved dramatically in the last decade. It's actually one of the success stories of regulation and one of the success stories of financial incentives to improve air quality. All that was erased in the last year and a half, unfortunately. So after COVID, like many things, all those things were put on hold because of the need to keep the economy going, because of the need to continue to focus on the pandemic versus these other regulatory measures. And so air quality now in Los Angeles is approximating what it was about 8 to 10 years ago at this point. So we're going a little bit backwards. So air quality is measured in many different ways, but for the most part, many people have studied the most studied version of air quality measurements, and that's called PM 2.5 and PM 10. And PM 2.5 is otherwise known as particulate matter 2.5. It's those elements of things floating in the air that we can see that are 2.5 microns in size or smaller. The reason why that's important is because those can penetrate deeper into the lungs. The smaller the particles, the less our body's able to defend against them, and they drift right into lower airways. In fact, at this point, if you talk to an environmental health scientist and pulmonologist, PM 2.5 is probably at this point not just associated with asthma development and severity of asthma, but it's probably causal at this point based on a decades worth of work and decades worth of studies. And it's an exciting area of work. Then there's PM 10 as well that affect the upper airways as well. You can imagine a fine piece of sand is 90 microns in size, so this is incredibly small that we don't see, that we breathe in on a daily basis. So if I were to ask the question, what is the air quality exposure that our patients experience at home, whether they're adults or kids? We couldn't answer that, right? Our electronic health records don't have that information. And despite the fact that we know that asthma is almost causally related to PM 2.5 and poor air quality, we still can answer that for our pulmonologists, for our pediatricians, for ourselves as anesthesiologists, right? And the work that we're doing is able to do that again here. So if you look at this map here, these are 2,500 kids that got elective urology surgery at our hospital in the past year. And so while the kids come from a larger area than the map shows, we'll just focus on this area here. So there are over 2,500 kids on this map. And then what we did was we took that and we mixed it in with other air quality data. So this air quality data comes from AccuWeather, and it's at fine levels of geography. So this air quality data is actually at 1 kilometer intervals. So meaning the idea is that if I live in Glendale and Rebecca lives in Burbank, that's many kilometers away. It's probably 5 or 6 kilometers. And there's 6 or 7 different measures of air quality differences throughout that. Because there are microclimates in our city and in most cities, the microclimates of air quality changes, and so our exposure is different. So looking at this map, this is the average annual PM 2.5 levels in Southern California. The red color is clearly the higher exposure on average per year, and the yellow color is those with less exposure. And so if you just look at this, it looks like it follows major roadways, major highways, and that makes a ton of sense in terms of where PM 2.5 comes from. But also if you look to the right of the screen, Rancho Cucamonga, there's actually not a lot of car traffic that goes out there. It's halfway from Los Angeles to Palm Springs. But if you look closely at the geography of that part of the area, what you'll find actually is that there are a lot of factories there, and there's a lot of industry there. And on top of that, there's not a lot of air movement. So that microclimate of no air movement, a lot of heat, generates a lot of PM 2.5 levels. And so then we can do this very much in the same way with PM10 and other measures of air quality exposure. And all this data comes from AccuWeather and Plume Labs. And then we can do the same thing again with NO2 levels in Southern California. NO2 is very much an air quality measure that actually leads to reactive airway, and when that happens, that also can lead to severe asthma and reactive airway disease. Many of the diseases that we care about as anesthesiologists. So the magic really comes from taking those maps and that data and bringing it together with our 2,500 kids. And really that's combining our electronic health records with air quality exposure. And so what does that look like? And this is actually a really exciting graph. When we finished this part of the study, we were really excited because this is the first time that we're looking at scale, right? What is the air quality exposure of the kids that get anesthesia and surgery at our hospital? In fact, really, if you look in literature, this hasn't really been done before at this scale. And so every dot there on the map on the left represents an individual patient, and every color there represents the air quality exposure that they're exposed to at home. And if you take a look, let's say this child lives in that part of the city, that's just south of downtown Los Angeles. They're exposed to about 12.5 micrograms per kilogram of PM 2.5. That's very different than the child lives in Calabasas. Right? This is almost a difference of 30-40% reduction in air quality exposure year over year. That's very different than the child that lives in Rancho Cucamonga, who's very much close to the highest exposure in our cohort. And really the question is there a difference in disease and clinical outcomes in anesthesia care that we provide related to the group in the red, right, versus the group in the yellow? And if there is a difference, can we do anything about it, and how can we modify that? And to give a measure of understanding what these numbers really mean, the WHO has annual mean limits recommendations that they provide. I would say a little bit more than half of our kids live above the WHO recommendations for PM 2.5 exposure. And that's really interesting to even think about in terms of the population that we care for. And we can do the same thing for NO2, for example, and look at the fact that the kids down here in the yellow box are actually exposed to 25% of the air quality that the kids on the right-hand side of the scale are. That's a dramatic difference, 2 to 4 times difference in NO2 exposure. And what does WHO say about this? Well, the annual mean limit is 10 mics per meters cubed. And this is not a visual or a typo or image issue. All of our kids live above the WHO NO2 recommendations. Again, we're going backwards in terms of our air quality exposure in Los Angeles. So to go even further with this, and this is setting us up for how this applies to anesthesia, there's outdoor air quality exposure, which we spoke about. And there's individual air quality exposure. So we can give a smartphone to our families, which we're about to do, an air quality monitor that's portable, Bluetooth enabled, to our families, and they can carry that and place that in the child's bedroom at home. And then you can have measures based off this low-cost air quality sensor and a smartphone of the air quality exposure inside their house. And you can start collecting data about what that looks like. And there are differences. Individual exposure also is not just about the exposure in one space, but it's over areas. And so I live in Glendale, California, and that's about 4 miles from our hospital. And this is my commute at 10 o'clock in the morning on the way to an afternoon call, right? And so the colors represent really not great air quality in red, and then it turns purple right in the middle of that. And then it gets better as you get toward the hospital. But at 1:30 in the morning, when you think there's no cars out in the road, there's nobody there, at 1:30 in the morning when I'm driving home, the areas around Glendale are green, right? So that's really great air. This is my windows open in my car. And yet there's this area over at Water Village that's purple or dark red, right? Still there, even at 1:30 in the morning. And that's because that bridge, where that color is, crosses over I-5, right, a major interstate. And so if you live just a block or 2 blocks, 3 blocks, 4 blocks from I-5, no matter what time of day you have it, you're going to be exposed to worse air quality. And you can imagine that these major interstates cross throughout our cities, and they cross through certain neighborhoods, and your exposure is differential based on that. And if you're in Kenya, before the pandemic, we had gone out there for a medical mission trip, and this is one of the most dangerous roads in the world, one of the most highly trafficked roads in the world, and with the windows open, it is very hard to breathe there. But these sensors can actually detect all these things. And so how does this apply to anesthesia? And this is the exciting part of our future, right? So all this, all put together, is meant to set us up to do the real study, right? The real study is to determine, does air quality influence perioperative respiratory adverse events? And so for pediatric anesthesiologists or any of us that take care of kids, respiratory adverse events during induction, emergence, and recovery, things like laryngospasm, bronchospasm, low saturations, severe coughing, those are the most common safety events that occur in children for elective surgery in healthy kids. And so this is a major issue depending on what literature you look at and what population, whether OSA, TNA kids, that can be between 5 and 20%. And so this is a really important population for us to study. And while we know that black children are more likely by 2 to 3 times more than white children to have certain adverse events, there's 2 studies out on that. There's on the environment and the exposures that they have in their household and outside. And if we know that bad air quality leads to asthma and reactive airway, and that's causal at this point, and we care about asthma for the care that we deliver as anesthesiologists, why aren't we thinking about air quality at their homes? And if we do, and we can measure that ahead of time, maybe we can do something about that. So what this study is setting us up to do, that the APSF and FAIR are funding, is to take healthy kids, the ages 2 to 9 years of age, getting elective urology and ENT surgery, and we're prospectively going to look at their street address and put them on a map. And then we're going to take their outdoor air quality information based on where they live for the past year, and also in the 7 days leading up. 7 days is a great window to capture an acute airway inflammatory event due to a change in air quality from a wildfire, for example. And then we're also going to give them a smartphone and then an air quality sensor to measure indoor air quality in their home. And then we're going to put them to sleep with a mask induction. And with a mask induction, without an IV, this is the window of risk, right? And we'll have a blinded, trained nurse researcher that'll look for these adverse events that happen. And the idea is, our kids that live in worse air quality environments, indoors and outdoors, are they more likely to have a respiratory adverse event? Because if that's the case, that changes the way we think about anesthesia, that changes the way we think about mitigating risk. And there are many things that we can do at the individual and the system level to improve that safety margin for our kids that are highest risk to the environment. So just to end up here, we're innovating pediatric healthcare using location factors, spatial science. And we talked about the social determinants of health risk factors. And we're using this information to help us understand patient location, site suitability for advertising, or maybe a clinic, outreach, immunization clinics, looking at social vulnerability and other measures of economic status of the patients that we serve across our enterprise. We're also looking at different measures of environmental justice and tree cover and shade and green space access. If you live further from a park, you're more likely to be obese or have hypertension. In adult literature probably translates to children as well. We're also looking at air quality, extreme heat, and weather. We're looking at doing statistics on these patients and using these risk models to help us understand how we better run our clinics, how we better run our operating room potentially, using hotspot, cold spot analysis. And then lastly, very exciting, we're also looking at drive times. So this is a map of driving distance based on roads, based on time of day, and we're just starting this work. But we're able to look at how long it takes to get to our hospital or to our clinics based on drive time at different times of day. And maybe that should influence the way we schedule our kids or think about at least who's at highest risk for not showing up physically in person. And so that's a drive time network analysis. I'll close up by just having us imagine what our city looks like, wherever you live. This is the city of Los Angeles, and imagining where all of our kids live, looking at the different neighborhoods and thinking about who's at highest risk. Are there stories that you think in your head and you look back on, there's a certain population of kids are always having trouble with something. And I would ask and challenge yourselves to think, is that related to social, economic, environmental, educational issues? And if they are, well, we should start studying that. And we finally have a way to actually integrate our electronic health records now with these social and environmental factors. And we can start thinking very much differently about the way we think, care, and safely get our kids through anesthesia and the perioperative process. I'd love to talk to you more after this. I know we have a Q&A session, but please feel free to reach out to me. I'd love to see how we can help you think about this and work through this more. Thank you.
Vascularity and just their age and things like that, it's essentially non-existent. The headache does not occur. I've never seen it. I've never had it. I've never had anyone complain about it. I think you would be worried about it, especially with a 22 gauge needle that we're using in the back of in some of these kids. But that coupled with the fact that most of these infants are younger that we're doing them on, and they're laying anyway, I don't know that we would have any way of monitoring that. Whether or not they're irritable is, I guess, the way that we test it. But I don't see that it's happening at all. So
thank you.
Yeah.
Dr. Geller.
Jess Geller, Omaha Children's. My question is on the environmental studies for air quality is surrounding reactive airway, which is part of the outcomes you're looking at. When you're doing these monitors, you have the air pollution factor. Do you also look at exposure to passive smoke as another reason for reactive airway? And coupled with that, when you're looking at intervention opportunities, one of the things that I've taken to doing because of what we see post-operatively is doing a pre-operative albuterol when I think they have a higher propensity for a reactive airway. Related to those two areas, are those factors that you consider?
Yeah, very much. Thank you for the important question. There's no question that smoking, right, in the house leads to adverse reactive airway disease and perioperative adverse events from a breathing standpoint. I think that's been really well studied. In our study, we're actually going to rule them out. We're ruling them out because when we brought these monitors inside individuals' homes, if you have an indoor smoker, they're just through the roof, and we're not going to find any differences there. And so I should clarify that the kids that we're enrolling are ages 2 to 9 that are non-cardiac, non-smokers in the household, and that's part of a pre-screening that we're doing because that's something that I think our field knows very well, and that's why smoking is not great. And then in terms of mitigation, yeah, you highlighted all of this is the idea of risk stratifying these kids ahead of time. And so for sure, there are ways that we can modify how we care for them perioperatively. So albuterol nebulizer, albuterol puffs electively before their procedure, maybe the night before, certainly have already played an important role at reducing this risk. IV induction over mask induction, maybe spinal for some of these younger kids, all help to contribute to reducing the risk as well for these children. The idea is, how do we better identify who these kids are? Because we've noticed that there are kids who don't have a diagnosis of asthma or reactive airway disease that do have what seems anecdotally to have a higher risk of respiratory adverse events perioperatively. In the last few months, There are some case series and case reports when there are wildfires in Denver or wildfires in Seattle or Oregon, rather, that these kids that don't have any diagnosis of asthma or reactive airway disease are having trouble under anesthesia. And so how do we identify those kids as well?
We actually had experience of some of the smoke from the wildfires making it all the way to Nebraska back in the day. So, but
thank you.
Thank you very much.
Appreciate both your talks. Really cool topics. Two questions for Dr. Mitchell. For your outpatients, are they all getting IVs, replacing those? And if so, at what point in the process? And then as somebody who's comfortable with adult neuraxial, as a fellow I did a couple epidurals in asleep children, and now I do the occasional caudal. Any suggestions on how to get experience with the neonatal spinal? I don't live in Ohio, so I couldn't swing by your institution, but is there enough difference between the procedures that you would recommend hands-on somewhere before doing that?
Yeah, sure. To answer the first question, in the outpatient surgery center, I can speak to the IV situation that I did. I had 6 cases last week. Total of 8 cases, urology, anywhere from hypospadias to circumcisions to inguinal hernias. And urology kids are the fattest, chubbiest, healthiest kids
So
that
cute.
you possibly can work on, and can be one of the most difficult IV access kids that you can have as well. As soon as the spinal is in and we put them on that little towel on the back, I have the CRNA come down. There's a nurse in the room that kind of is applying sweeties, trying to calm the kid down if they're crying or anything. For the most part, they're pretty much calm. We're trying to get a saphenous vein right away. 3 cases last week. Couldn't get a saphenous, couldn't get a foot IV, and I just elect to not have an IV in that situation. Can you go up to the hand? Yeah, you can do it, but then you're going to institute a situation where a kid's crying and are under pain. So if I am under the impression, or if I am giving this talk and telling you about the cardiovascular stability and how safe this anesthetic is, I would want to be able to put my money where my mouth is and say it's so safe that I don't even need an IV for the situation. I don't recommend it, but it's a situation also that if you get an IV, it's good for sedative purposes if you needed something, or if there was, heaven forbid, something that went on. That being said, I do them without IVs a lot. So as far as the doing the technique for someone who is familiar with adult, I think a spinal in a neonate or infant is super easy. It's on the holder. I wasn't lying when I said that. The person holding the kiddo is especially if you're using a 22 gauge needle, if you find the top of that iliac crest and you go over and you're at that L4-5 and you stay midline and you go in, you will get CSF. I mean, it's a pretty straightforward procedure. That being said, I would love to, I can give my email and things like that if anybody has questions. It's one of those things where I talked to my chairman about even going to different hospitals because I care and think so highly of this, to go ahead and try to create a situation where I or someone, or they come or we go, can help and go and try to get this rolled out to other hospitals as well. So I'd be happy to.
Thank you very much.
Yeah.
Question on the floor.
A comment about your work, Dr. Tran. There's an interesting article coming out in the November issue of Anesthesiology out of UCSF, actually, looking at kids who were giving anesthetics within 2 weeks after one of the 2018 wildfires. And there's a great accompanying editorial. And I'm actually interviewing the authors of those for a podcast. But they suggested, or their studies suggested, that there was about a 50% higher risk of significant adverse respiratory events in those children, only in the group that had reactive airways disease to begin with, but actually just mild reactive airways disease. They didn't have to have severe disease, including intubations, reintubations, not just desaturations or laryngospasm that we can often take care of. So it's actually very timely and very important. And they actually, discussed maybe this was a modifiable risk factor that we should, reassess giving those children anesthetics within that period of time. What do you think of that?
Absolutely. The idea of the individual things that we can do to modify their risk also extend into delaying their procedure. Maybe one day we think about these kids, if we have the great risk stratification of saying these kids should be delayed 2 to 4 weeks, maybe similar to our URI children, because the risk is similar. And that's really exciting work. And on top of that, there's other things that we can do as well. When we're working with the University of Southern California, they have a really great communications arm with environmental health. And part of this grant is actually to fund education of the families. And the idea that perioperatively, in the days leading up, if there's a wildfire or if there is just poor air quality due to a variety of reasons that we're detecting, that they should shut their windows and their kids should stay indoors. On top of that, there's a really great study from pediatrics from about 3 years ago, randomized prospective study where they took severe asthmatics and they placed in some of these children's homes, in their bedrooms, air filter, $200 air filter. And in the other kids' rooms, randomized to a sham filter. The filter turned on, lit up, but never filtered anything. And there are dramatic changes and reductions in the severity of asthma exacerbations throughout the year in LA. And so that is a really great, I think, powerful use of a device that actually doesn't cost that much money, that plus Windows, to help reduce risk perioperatively. And that's really important. And I think I'm looking forward to reading that, the manuscript.
Dr. Hefnagel.
I have a question for Dr. Mitchell, real quick. For your kids that get spinals, do you see urinary retention, and do you require them to urinate before they go home?
So no, we not really seeing any retention of the urinary tract system, anything like that. And no, really, we're not, for the urological procedures, they're not, for the hypospades, sometimes they'll cath and things like that, but for the most part, we're not seeing any of those things. And as soon as they're moving, like I said, we're getting them home, out the door, so.
Dr. Proctor.
Thank you both for the excellent presentations. I know we're running short on time, but I did have 2 questions for Dr. Mitchell. You had mentioned some of the barriers and challenges in terms of initiation of a spinal program for neonates and young children. Do you think that would be feasible at an academic institution where you do have residents, fellows? The anticipated surgical time would be a little bit longer. That's question number 1. Question number 2, I think, is a brilliant solution. Going on Amazon, getting an iPhone holder and putting on Paw Patrol. So my second question is, what's your favorite Paw Patrol character?
Yeah, Sky probably. Yeah. I think the rolling out at an institution is change is so hard, right? I mean, it's difficult for anyone to want to do anything different. I have anesthesiologists who are in our group that probably roll their eyes when I'm not around, right? So, because we have something that works, we do a general anesthetic with a coddle and we move on. And they would state that you're only saving 15 minutes maybe, or, but that's not necessarily what it's about for me. It's all the problems that you can have with the airway and things like that, right? So the proof, I always say the proof is in the pudding, right? So at first when you're rolling this out, there's nurses in the room that you have to educate and say, listen, the baby's going to be crying, all right? Like you're used to a mask on a baby falling asleep, IV, it's a calm environment, calm situation. You have a crying baby, but you know, every one of these nurses, circulators, surgical techs, everyone in that room, after they're in that room for a day, and see if we do 5 in a row and then see general anesthetic the day before or after, everyone comes around and everyone's like, wow, this is amazing. Like, this is absolutely amazing. And so I like the naysayers, and I invite them in the room and I say, come in, I want you to see what this looks like. I want you to see how beautiful of a procedure this is, how beautiful this sets up, how awesome it is afterwards to just bring them up in a blanket and hand them to mom and dad, who are literally waiting for you in the PACU, and just grateful that their kid didn't have, I mean, parents are so scared of general anesthetic, and you do a spinal on them and they know that their kid's not asleep and can watch Sky or Chase. Yeah, so it's not easy to roll out because of those individuals, but proof is in the pudding. Just do it and they'll see how great it is. So.
Good morning. Your agent of choice, you talked about 2-chloroprocaine. How about 2% lidocaine or 0.25 or point marcaine? Plain.
Bupivacaine?
Yes.
Yeah, so 0.5%. I've been using the one with epi, actually, because it's interesting. At the beginning of starting this out, rolling this out, we were using 0.5% plain marcaine, and great CSF flow. Put the syringe on, inject, and I would have one kid that seemed to be feeling something and others that didn't. And so I got to the point where I would use a vial, and if it looked like it's set up really well. So there is for sure at the beginning, I don't think it's user error. I think it was medical. I'm always going to say that the medicine was, because it was splotchy, it was weird. I'd have a kid that had perfect block, looked like it would set up, and for some reason wasn't. I'd sit him back up and do it again. And I think it was the marcaine at that point. Currently, I'm just, because I've gotten used to using the 0.5% with epi, I'm using it. But we do have the plain. I'm just afraid to use it because I got hosed by it a few times.
Okay, I don't know if this translates to the pediatric population, but in the adult population, I was actually increasing the dose for longevity. Are you seeing the same thing with the kids?
So the difference between my 0.5% with and without, with epi, I'm getting close to 70 minutes. So without is 55. So I am getting a longer block with the epi for sure. And it's not getting as long of a block as if, for say, if I use the 0.5% with epi, I'll still add the clonidine to that as well, though.
How about pushing the dose, though? Are you worried about that? It is not technically isobaric, but you shouldn't get, spread.
Yeah. So it's all been good with that. So.
Okay, thank you.
Yeah, thank you.
Anybody else have any questions? All right, well, please help me appreciate and applause for Drs. Mitchell and Tan for the two fascinating presentations. They'll certainly be around if you have further questions. We're going to adjourn for a break and return at 10 a.m. for the next session. Please remember to visit our booths and show your support. Thank you so much.